Good evening, everyone. This is Elise Kramer on behalf of the Scleral Lens Education Society. Thank you so much for being with us tonight. We have a very special speaker with us, Dr. Gloria Chu. She is an associate professor of clinical ophthalmology at the USC Roski Eye Institute, Department of Ophthalmology at the University of Southern California Keck School of Medicine. She received her OD at the University of California, Berkeley School of Optometry, and completed a residency in cornea and contact lenses at the Southern California College of Optometry, where she still serves as an adjunct faculty member. Her clinical interests include contact lens fittings and treatments for patients with ocular surface disease and irregular corneas. Her research interests include microbial contaminations in contact lens related solutions and effect of scleral lens wear on the ocular surface and optic nerve. Dr. Chu, thank you so much for being with us tonight. It's really an honor to have you.
Thank you so much, Dr. Kramer. Welcome, everyone. Thank you so much for being here today. I have to start out by saying that you are absolutely my favorite group of eye care practitioners. We share an interest for specialty contact lenses and particularly scleral lenses. This is the Scleral Lens Education Society. And you know, it has been a little over a year since this pandemic started, and we've been isolated in many ways, geographically, physically, except for Dr. Kramer in Miami, as she was sharing earlier. And I'm really grateful, though, for opportunities that have allowed us to remain connected and engaged. Social media platforms, virtual meetings that we've all at least attended a couple this last year, and webinars like this one today. So I wanted to thank the Scleral Lens Education Society for this opportunity. And again, thank you all for spending this hour with me. That makes all of you guys and gals even more awesome. So Dr. Barry Iden gave an excellent talk a month ago on part 1 of this webinar series on myths and misunderstandings of keratoconus detection and intervention. So I am going to continue on that theme, switch it up a little bit, and change it to myths and misunderstandings of contact lens management in keratoconus patients. Here are my financial disclosures. So the first one I'm going to start with today is that glasses do not work for keratoconus patients. The truth is that glasses often work really well for mild keratoconus patients, and even in advanced patients, glasses are always helpful for emergencies. So I would say consider prescribing an accurate prescription for the milder eye that the patient can see better out of, and balance the other one if you're unable to get a good prescription with good functional vision. You can also, for patients who aren't thrilled about contacts, fit a contact in the eye that requires it and glasses in the milder one. And for presbyopes, I do this often. If they have to wear bifocals or progressives anyway, it gives you a little leeway, because if you have a little bit of residual astigmatism, you can put it in the top of the glasses and then put their ad in the glasses over. So glasses can work in that way for keratoconic patients in their mid-40s and over. So you might say, okay, glasses work, but it's hard to get to that endpoint. So I wanted to share a few tips when you're refracting these patients. So first of all, we all know that retinoscopy can be very challenging in keratoconic patients. Even in mild cases, you may see scissoring when you're using your retinoscope. And then if they have scarring in more advanced patients, you see like a black shadow. So it affects your ability to do accurate ret. I would say use large jumps. Start with that large 3 diopter knob in the corner. And sometimes what I do is put 1 to 2 diopters of cylinder in your JCC, in your cylinder knob, and then turn the knob like a TV knob until the patient says, okay, that's a little bit better. Then once you're in the ballpark with the 1 or 2 diopters of cylinder, you can then refine the axis and then the amount of cylinder. And then lastly, refine the sphere. So go in big jumps and don't be discouraged if you can't get a good accurate refraction. One thing I also want to mention is that you need to have a decent best corrected vision to give them the prescription. So one thing I like to use is kind of the DMV requirements in California. So the DMV in California vision screening says that you need to have 20/40 with at least one eye and 20/70 in the other. And I feel like that works pretty well, even in glasses. So if you're able to get at least 20/40 in one eye, I would say 20/40 to 20/70, that at least gives your patient functional vision. So if you're only refracting to 2200 or 2150, you may not want your patient to spend hundreds of dollars on those glasses, which they're going to end up just keeping in a box in a room, and it won't be usable for them. So let's talk about, how do you use information from your autorefractor to help you. So I'm going to show a few examples here, and I wanted to start out by saying that the more advanced your keratoconus is, the more useless the results become, particularly for the refraction information. So you get inconsistent readings and you must manually refract. However, I will say that the K readings can often be helpful. So here's an example, a 68-year-old female. I just saw her a couple weeks ago, has been wearing scleral lenses for 6 years and RGP contacts since she was a teenager. She has moderate keratoconus in her left eye and less in her right. She does have some scarring in her left eye. So here are results of her autorefractor. These are her results. You can see that she's getting error messages in both the right and left eye. However, in the left eye, you can see that the refractive error amount is larger. And then it's also helpful to look down at these keratometry readings, and you can see that there is some asymmetry. So in the left eye, you're seeing Ks in 53, 47, and then in the right, 50 and 45. So although the refraction results may not be accurate, at least in the keratometry readings, you can see that the left eye is steeper, more advanced, and maybe consistent with kind of higher numbers in the left eye. So in your advanced cases, you're going to get error messages. Here's another case. This is a post-transplant keratoconus patient, 80-year-old, has been wearing scleral lenses for 10 years. And look at this refraction here, -14 plus 10 in the right eye. And he sees 20/40 with this in his right eye, -16 in the left eye with some SIL. Not as good vision, but this gentleman loves his glasses at night, in the morning. It's actually functional for him with that 20/40 vision. His case, his cornea is so irregular that with tomography, you're not getting good readings at all. But these glasses were prescribed by his referring optometrist. I send this patient back to that same optometrist every year because he must be using some crazy, SIL, what are those that you add on to increase the SIL to get to 10 diopters of SIL. So I send this patient back to the optometrist every year. The only glasses I gave him were with a little bit of over-refraction in the distance and the ad for his progressives. So here's another case, a 15-year-old Caucasian male. He presented to me for the first time with incoming uncorrected vision of 2300 and 2100. So glasses did not work for this patient. And if you look at the autorefractor results, you can see why. The right eye gave me nothing, not even an error. And in the left eye, we're getting -25 with 13 diopters of SIL. So clearly something is wrong with the corneal surface that you can't get accurate readings. However, again, looking at the Ks, I am seeing some asymmetry. The right eye 65 and 56, and the left eye 61 and 53. So definitely steeper in the right eye, higher values, worse vision in the right eye. The refraction, we didn't really get anywhere. And, this case was actually a bit heartbreaking for me because this young boy has a history of behavioral issues, and his vision, I believe, got progressively worse during COVID. He has been struggling in school, and for years prior, his mom told me that, you know, the eye doctors weren't sure if he was telling the truth when he said he couldn't see. And it could have been that the presenting signs of his keratoconus were just so mild at that time. However, when I saw him, it had become advanced keratoconus. He has central thinning, striae, and scarring. And I wanted to show this case because it just shows the urgency and importance of trying to detect those very early signs of keratoconus, because this article published in 2019 in Ophthalmology states that younger patients, particularly those under 17, and those with the K max steeper than 55, have a significantly greater risk of keratoconus progression. This other paper that I just came across that was published just a couple months ago, also on the impact of COVID-19 on keratoconus patients waiting for corneal cross-linking, I thought was very interesting. And they showed that in 46 eyes, 70% showed progression as they were waiting for cross-linking. So just kind of to get in our minds the urgency of getting our young keratoconic patients seen and treated as early as possible. And I'm happy to say that this patient was seen in our clinic today with my corneal specialist, and he's going to get cross-linking very soon. And here are actually the corresponding topography images of that young 15-year-old boy. So you can see very advanced keratoconus here. So this case is a very unique case I wanted to share. So glasses for this patient. This 31-year-old male was actually referred to me for contact lenses. However, his uncorrected vision was 20/30 in the right and 20/20 in the left. So this gentleman was actually getting by life fine because of his good vision in the left eye. I refracted him to 20/20 in each eye with glasses. So in the end, I did not prescribe contacts for this patient. I prescribed glasses and said, look, you're seeing 20/20. There's actually no need for contacts. So I want to point out some features on his autorefractor slip. So here we're seeing a few interesting findings. In the right eye, you're seeing more myopia and higher astigmatism than the left eye. You're also seeing asymmetry here in the K readings. In the right eye, you see Ks of 47 and 44, and in the left eye, 43 and 42. So if you're working and you're busy in your clinic, you might not think very much of these asymmetric findings, and you're refracting this guy to 20/20. So what's the big deal? Give him his glasses and let him go. However, it turns out that this patient was actually referred to me by a glaucoma specialist because an optometrist had referred this patient to him for suspicious looking optic nerves. He had C to Ds of about 0.7 and 0.8, so I completely agree with that. But as the glaucoma specialist was seeing this patient, he found this when doing corneal tomography. So in looking at this, it's pretty clear that there is inferior steepening in the right eye and some kind of unusual findings in the left eye. So this patient has mild keratoconus, and he's actually been getting by in life very well because of that left eye, and he's just been telling people, oh, my right eye has never seen well. So I don't know how long he's had keratoconus, but it's very obvious when looking at this tomography scan. And in the left eye in particular, if you can see this, I'll read the values if you can, I want to point out that posterior elevation is a very important finding when looking at tomography. If you're seeing numbers of elevation over 15 to 20, that should make you suspicious. And looking in this posterior elevation map of this patient, we're seeing values of about 25. And you also see a little bit of asymmetry here in his inferior cornea. So in this case, it's interesting because glasses worked so well for this keratoconic patient that his condition went undetected for probably many years. And another reason why I bring this case up is because I want to demonstrate that it's really easy to miss subtle signs of keratoconus. And it is my hope that we as optometrists will screen for keratoconus with the same intensity and rigor that we screen for glaucoma. This optometrist is a friend of mine. She's smart, she's residency trained, and on a busy day, it could slip by any one of us. So it's just kind of a reminder that we want to look for things that look a bit unusual and that may raise a red flag for keratoconus. And here's just a demonstration of a normal cornea. Posterior elevation is only about 13. And this is a normal shaped cornea. So I promise that all of my misunderstandings are not that long. I just had a lot of interesting cases I wanted to share up front. So the second one here is that soft contact lenses do not work for keratoconic patients. And the truth is that they do work well for mild cases. However, you need to get adequate refraction results. So we have toric and specialty lenses are a good option. Watch for fluting, as you can see here, where the edge of the soft lens may kind of curl over a steep cornea. There's custom toric lenses, and then the Biofinity XR, actually, you can get cylinder up to 5.75 diopters and 5-degree steps. So another good option. The other day, I had a keratoconic patient who had been referred for scleral lenses, but I was refracting him to 20/20 with glasses and he wanted contacts. So I said, let's just do soft lenses, and ordered some Biofinity XR lenses for him actually. There are also specialty soft lenses for more moderate cases like the Novacone, the Kerasoft IC, and the Kerasoft Thin. But keep in mind that these soft lenses are thicker. They actually used increased lens thickness to control for the irregular astigmatism. So be aware of hypoxia in these cases. And sometimes they're so thick that they can actually rub on the cornea and cause staining. So be careful of that. And also with soft lenses, there are challenges with higher order aberrations. However, I'm excited and I'm aware of ongoing research that may actually help with these higher order aberration corrections, even in soft lenses. And here's a slide that was shared to me from Dr. Daniel Fuller. He gave a wonderful talk on specialty soft contact lenses a couple weeks ago. And this just demonstrates that in a -12.75 and a -13 diopter lens with similar power, it is 470 microns thick in the Kerasoft IC compared to the Biofinity on the right, which is only 155 microns thick. So those soft lenses that control for irregular astigmatism are much thicker. So just be aware of that. The third myth and misunderstanding, RGP contact lenses should always be the first line contact lens modality fit. Well, when I was a resident at the Southern California College of Optometry in Fullerton 12, 13 years ago, the majority of lenses that I fit were RGP contacts. And, I was always trained RGPs for keratoconic patients. You always start with that. I think through my whole residency, I maybe had fit a dozen scleral lenses. And I know that's different for a lot of our contact lens residents today. But I want to remind you that there are challenges and difficulties with RGP contacts as well. So here's just a few examples. If you have intacs, the RGP, you're fitting speed bumps on the cornea, as Dr. Edrington would say. The contact can get stuck and very tight around those irregular curves. You can also get, with tight fits, you can get 3/9 staining, and also with central scarring, you can get dimple veiling, you can get strange bubbles and kind of irregular touch and clearance areas. So it can be challenging in the more advanced cases. But I always will start with an RGP contact. And also a lot of insurances, if you're trying to bill medically for scleral lenses, want to know if you've tried RGPs first. I've gotten some denials and said, well, what about, different types of contacts first? So you should always attempt an RGP during a consult. But if your patient is miserable and tearing, I think it's okay to move on pretty quickly. You also want to make sure to evert their lids and look for papillae, because the RGP could potentially exacerbate kind of the papillae in the lids. And if you're fitting in scleral lenses or hybrids and you run into complications, you may need to revert back to an RGP. So make sure we still keep up our skills with fitting RGP lenses. So there was a study published last year by some wonderful group of optometrists led by Ellen Shorter, looking at RGPs versus scleral lenses. In this study, they found that GP wearers had more problems with lens movement and loss, and less problems with halos and lens handling. However, scleral lens wearers had greater satisfaction with vision and comfort, but both groups reported cloudy vision and lens discomfort at some point. So each modality of lens does have pros and cons. Another thing I want to point out is that wearing RGP contacts and even hybrid lenses can make monitoring keratoconus more challenging when you're doing topography or tomography. Here's an example here. An 18-year-old Indian female, a keratoconus suspect, family history of keratoconus in her mother. She was wearing soft lenses, then hybrids, for 6 years, and she was running into some challenges with abrasions and the fit. When I saw her, her hybrid lenses were pretty tight, so there wasn't much movement at all, and left this impression ring on her cornea and staining on removal. This was her refraction, definitely high refractive error there. But when I did a corneal mapping, you can see here a very irregular pattern. There's this flat zone here, superior nasally on both eyes symmetrically, and then a little tiny area of steepening. This is not a normal corneal shape for anyone. It doesn't look like keratoconus, it doesn't look like a graft, it doesn't look like a normal cornea, it doesn't look like astigmatism. So what you're seeing here is corneal molding from a tight hybrid lens fit, and you can get similar misrepresentations if your RGPs are fitting very flat or tight. So in monitoring keratoconus in these patients, you may actually have to arrange for them to come in without lens wear to get accurate maps to monitor progression. And if they can't be without their contacts and their glasses aren't functional, you may have to do one eye at a time. All right, moving on to number 4. Since keratoconus is not an ocular surface disease condition, midday fogging should not be an issue with scleral lenses. So let's talk about this. Midday fogging definitely occurs in keratoconus patients, and you need to watch out for this complication that is very troubling for patients and doctors and all patients. There's even been a few times that I have had to convert to RGPs if I cannot get rid of this clouding enough for patients in sclerals. So there's this study, again, by the same group of amazing female optometrists here. This one is led by Muriel Shornack. They conducted a survey from scleral lens practitioners, so it's very possible that some of you contributed to this study. The doctors, from the doctors, 25.8% reported had patients who self-reported midday fogging. They also found that this midday fogging was not associated with demographics, indication for lens wear, mean diameter, so bigger versus smaller, haptic design, toricity, spherical, their cleaner, their storage solution, or their filling solution. So it seems like it can happen to anybody. They did find, however, that patients who reported midday fogging more commonly reported redness or irritation with lens wear. So it's believed that there potentially could be an inflammatory factor contributing to the fogging, so that you might need to treat the eye, address the inflammation. It could potentially help with fogging. I know in a few cases I've tried like Alrex or even Lotamax for a short period to see if it's helped with the fogging. If not, then you need to change the fit. But it can be challenging, and I just have to share that I have been burned when I have tried to convert RGP patients to sclerals, and the fogging became such an issue that I had to go back to RGPs. So here's an example of a patient who's been wearing RGP contacts for a long time, for decades, and she just does not want to switch. She is happy and she's doing fine, and she doesn't get midday fogging at all because there's tear exchange and it doesn't collect in the fluid chamber. So here's a keratoconic patient. You can see some kind of unusual areas of apical touch and clearance because of her scarring, and her right eye, she had a transplant. Here's another patient, keratoconic post-graft, who was in scleral lenses but had challenges with clouding in the fluid and also in her corneal graft, ended up converting to RGPs, and she was actually much happier with the clarity in her vision. Despite this unusual looking fit, she is actually doing fine. Moving on to myth and misunderstanding number 5. Scleral lenses are the best contact lens modality for keratoconic patients. And coming, I think, from a group like this, and just knowing all the advances and improved technology that we've seen over the last 5 to 10 years, we might be conditioned to think that scleral lenses are the best contact lens modality for many patients, including our keratoconic patients. And well, scleral lenses are everywhere. They're in demand, they're popular. We're here because of the Scleral Lens Education Society. There's many more design options available, quad-specific designs, channels, microvaults, and impression molding, free-form designs, the use of profilometry to guide our fits, to allow for free-form designs, and even we're getting into correction of higher order aberrations. We have better materials and coatings and many more educational resources for doctors and patients. Dr. Fuller even reported on the safety and efficacy of scleral lenses for keratoconus, and this was published in OVS last year. So with all of that, my gosh, we would have to think that scleral lenses must be the best modality, but are they really? So first of all, consider the costs. The lenses are definitely more expensive for us as providers as well as the patient. Fitting takes longer, and the supplies. The study even showed that the care for scleral lens patients was more complicated than in RGP patients. So they have to buy different cleaners, different soaking solutions, filling solutions, and if they're having trouble getting them on, they're spilling their saline all the time. Plungers, potentially stands or lights to help with the application process. It also takes a lot longer, for patients to get them in because of the tools required. Consider the time for you as a doctor and also the patient. Consider their ocular surface. So if they have dry eyes or a lot of debris or clouding, this may lead to the midday fogging challenge. We have also learned over the last several years that there are a lot of fitting challenges and complications with scleral lens wear. Hypoxia, limbal bearing, edema, limbal thickening, conjunctival prolapse. Could that lead to, blood vessel growth in the long run? And in larger sizes, if a patient only needs it in one eye, sometimes you may get asymmetry in the palpebral aperture, and some patients don't like that cosmetically, where one eye may look bigger than the other. And then I touched upon this earlier, but be cautious of refitting RGP patients that aren't really complaining about anything. If they've been wearing contacts for decades and they're doing okay, and you ask them, does your lens pop out? And they say no, they're always going to complain about something like, oh, it's a little scratchy or it fell out once. But listen carefully, and if they're not really having a problem, you may want to leave them in their RGP. Another thing I want to point out is that sometimes patients occasionally can achieve better vision in RGPs compared to sclerals. And I've seen this before, not all the time, but something about the touch on the cornea. And sometimes maybe compensate for maybe the irregularity or maybe some of the higher order aberrations. I'm not exactly sure why, but some patients have trouble not getting as crisp vision in sclerals if they came from RGPs, some. All right, so since keratoconus patients have highly irregular corneas, well, their scleral shape must also be very irregular. So let's talk about scleral shape. Is there a correlation in corneal and scleral shape? Well, first I want to say that in my experience, keratoconic eyes or the sclera, if you're fitting a scleral lens, is not necessarily harder to fit. I would say the most challenging eyes for me to fit are those with dry eye from Stevens-Johnson syndrome. And I would say maybe some of the easier eyes for me to fit shape-wise are those with ocular graft versus host disease. They're also some of the most rewarding patients to fit. But keratoconus kind of falls in the middle. It's not always the easiest, but it's not always the most difficult. I have to say that if the cornea is very ectatic, you may have to use a larger diameter, and when you go into a larger diameter, the sclera becomes more toric as you go further out. So you may need a more highly toric design for your larger diameter lenses. So in looking at kind of shape and fit and centration, wanted to share a few studies here. The first one here that was published last year in Contact Lens and Anterior Eye showed that contact lens center thickness and mass did not significantly influence centration. Horizontal decentration was actually associated with nasal and temporal asymmetry in scleral elevation, and then vertical decentration correlated with central apical clearance. So I thought that was really interesting and practical for us. So if you're getting a lot of vertical decentration, maybe lower the vault a little bit. And in some eyes that are decentered horizontally, sometimes you can't do much about it because it's due to the nasal temporal asymmetry. This other study here, also published in Contact Lens and Anterior Eye, showed that corneal asymmetry was a poor predictor for the need of toric scleral lens at the landing zone in irregular cornea. So here it's saying that even if the cornea is irregular, you may not need a toric scleral lens in these irregular corneas. And they actually said it could have better predictive power in regular corneas. But the title of their paper was Relationship of Placido Corneal Topography Data with Scleral Lens Fitting Parameters. So they used topographical data to guide this study. This third study here looked at 20 eyes in 15 keratoconic patients, but they used the Pentacam, a tomographer, and the eye surface profiler, which is the profilometer. And they actually found that anterior corneal parameters associated with the level of scleral asymmetry and the orientation of the steepest area of the sclera. So they found that the flat and steep Ks were found to be correlated with scleral asymmetry, so that there was a relationship with the flat and steep Ks. However, anterior astigmatism showed poor correlation with scleral irregularity. They also found that posterior corneal curvature and thickness were not correlated with scleral asymmetry. So I think we're going to see a lot more studies and research come out as more and more of us are utilizing profilometry, and we'll be able to learn more about the relationship between irregular corneas and scleral shape. So here are just some examples of these amazing images that we can get from profilometry, looking at all the nooks and crannies on the sclera, pinguecula, and potentially, irregularities post-glaucoma surgeries. And you can see, are you seeing, with the rule, against the rule, toricity in the sclera. So just some examples of how accurate these maps can be. All right, number 7 here. Keratoconic patients do not typically struggle with dry eyes or ocular surface disease. So this is kind of, going on to what we discussed earlier about the midday fogging. Well, we know that happens in keratoconic eyes, but what about dry eye in this group of patients that many of us see in clinic? So a couple studies here showed that this first study looked at the association of keratoconus with blepharitis. So they looked at 50 keratoconic patients with 72 controls, and they actually found that the signs and symptoms of blepharitis occurred more often in keratoconic patients compared to healthy individuals. And they thought that this could possibly be related to eye rubbing and blepharitis-related inflammation, and that these things may also contribute to disease progression. So very important to look at your patient's eyelids. Do they have papillae? Do they rub their eyes? Do they have, floppy eyelids? We're going to go into that a little bit later. And in this second study, they again compared keratoconic and healthy patients, and they found that there is actually a difference in corneal sensitivity in keratoconic patients, and that this reduction of sensory input from the corneal nerves may actually contribute to these unpleasant sensations and might lead to impaired tear dynamics. So again, their nerves may be affected. I know many of us, when you look at the keratoconic cornea, sometimes you can see really prominent like corneal nerves that you don't see in regular corneas. So just be aware that their sensitivity may also be different. And looking at allergies. So when you think about dry eye, you're looking at the ocular surface, thinking about their symptoms. It's also important to ask and look for ocular allergies, or ask about their symptoms. So it is clear that there is an association between keratoconus and atopy. So atopy is essentially a genetic tendency to develop allergic diseases like asthma and eczema. And it's associated with a heightened immune response to common allergens. So it's also all over the literature that there is a strong correlation between eye rubbing and keratoconus, and not just like light, gentle rubbing, but knuckle rubbing. So if you ask your patients, do you rub really hard with your knuckles? They may say, oh yeah, I rub, or their spouse or their parent may say, oh yes, they definitely rub their eyes. So again, really important to remind your keratoconic patients to avoid eye rubbing, as this could lead to increased inflammation that could lead to further progression. So treat the ocular allergies. We have some great over-the-counter options now. I love that Pataday is now over the counter. Even the 0.7% olopatadine, which is equivalent to the Pazeo, is now available over the counter. There's also Zaditor, there's Aloe now that's preservative free. So a lot of great options that you don't need a prescription for. So don't forget to flip the lids. And I wanted to touch upon this case here, and floppy eyelids. So a lot of keratoconus patients not only have allergies, but have very loose and rubbery eyelids that avert very easily. Some patients may also complain about irritation upon awakening. When they do, ask, what is their sleep position? Do you sleep face down? Do you always sleep with kind of one eye in your pillow? And ask about snoring, because this is one sign that they could be developing obstructive sleep apnea, where their airways are blocked and they temporarily stop breathing at night. So you could consider referring them for sleep studies or getting treatment with a CPAP machine to help with the airflow at nighttime so they don't stop breathing. So you can see here, it's very easy to evert this patient's eyelids. You literally touch the top and the whole thing everts. And these were his corresponding tomography maps. It's a 44-year-old male, advanced keratoconus. And I think, as we know, there's a genetic factor for keratoconus and also an environmental factor. And in this case, I think the rubbing and the floppy eyelids and the rubbing against the pillow may have contributed to his progression. So he actually had cross-linking only about 3 years ago in his early 40s in one eye. And I saw him recently and started to see some changes in his right eye. I actually referred him for cross-linking about a year ago, but due to insurance challenges, he hasn't been able to get the cross-linking. So if your patients have allergies or floppy eyelids, follow them even more closely, because their keratoconus could potentially be progressing more because of that environmental rubbing factor. These were his corresponding anterior segment OCTs. You can just really see the steepening in his corneas. So if a patient has been stable for many years and their topography and tomography, so maybe these monitoring is not as crucial. So although it is true that progression over time, when you hit your late 30s and 40s and 50s and 60s, you shouldn't be expecting progression. It is still possible. So as I shared in this earlier paper and in this one listed here, there is a high risk of progression in young patients. When I say young patients, I don't mean your 5-year-old or 6-year-old. I'm talking about your early teens and maybe early 20s. So again, steeper Kmax and younger age were the most clinically useful baseline predictors of progression. And in that case that I just showed you, that gentleman was 44 years old. He just had cross-linking 3 years ago, and I sent him for cross-linking in his other eye because I'm seeing some changes again. So it's still important to follow your patients closely, and I think they just will have, be at ease and have a better peace of mind knowing that their disease is stable. So not only checking for progression in keratoconus, but don't forget that they still need routine eye care to monitor their vision, corneal health. They could potentially develop complications like hydrops. Don't forget to dilate them. They can also develop glaucoma and cataracts. Also, kind of a topic of interest, and a lot of research has been done recently, looking at the effect of scleral lens wear on IOP. So I have an interest definitely in this topic. I published a paper a couple years ago, but only looked at this correlation in ocular surface disease patients. Currently, the results are mixed in the literature about whether scleral lens wear may affect IOP long term, but I can say that in the last 12 years of fitting scleral lenses in a lot of different patients, I haven't seen more glaucoma development in my patients. So just from my clinical experience. But again, as we're fitting more and more scleral lenses, we'll continue to look at potential effects on the eye itself. And also, don't forget that you will need to update their contacts or glasses after cataract surgery and any procedures that they may be having. All right, so I really like this topic here. Contact lenses will not help patients with central corneal scarring. And I work in the Department of Ophthalmology. So I work within the cornea division in ophthalmology. And I do believe, and my colleagues have told me, that since I have joined their department, they're doing much less corneal transplantation for keratoconus patients. They typically will send the patient to me for an evaluation to consider, non-surgical specialty lenses before they cut the cornea. But I wanted to share a few examples here. Here's a patient with advanced keratoconus, clear central scarring, but with a scleral lens, he was seeing close to 20/25. So he did not need a transplant and could wear a scleral lens for better vision. Here's another patient in his late 70s, and I've been seeing him for about a decade, and he has remained at this level of 20/50 to 20/70 vision forever, even with kind of this significant central scarring. We've talked about, do you want to have a transplant that might improve your vision? He's just been so reluctant to have surgery, and he's had this 20/50 to 20/70 vision. And as many of you know, when your keratoconic patients come, they have good days and bad days. Even in the same eye with the same scarring, sometimes they're 20/50, sometimes they're 20/70. There can be some fluctuation. Here's another example here A young female in her 20s developed corneal hydrops in the middle of the height of COVID. I think it was April of last year, and she called and said, I woke up with a white spot on my eye. So here you can see a close-up of the scarring. This is actually after the edema had resolved, and she has this residual scar. You can see actually a clear line of the split where the Descemet's membrane had split, but she was getting 20/50. Interestingly enough, she was able to wear her same scleral lens after the corneal hydrops, and I only found an over-refraction of about half a diopter, and she chose to stay in the same lens. So kind of interesting with that. Here's another young patient in her early 20s, advanced keratoconus in her right eye. You can see significant scarring after corneal hydrops here, and here's a close-up. She also gets about 20/50, 20/60 vision. So in all of these cases of really significant dense corneal scarring, sometimes patients are functional and would rather not have surgery. I do have to say that some of the most devastating cases that I've seen are in patients who had a corneal transplant for keratoconus and subsequently developed glaucoma and became blind. So here's a patient of mine who had a transplant in his right eye decades ago and subsequently lost all his vision to glaucoma. In his left eye, he gets 20/20 vision with the scleral lens. So this study that came out in Cornea just this year came out of actually Kellogg. The study concluded that physicians should maximize use of scleral or RGP contacts because patients who successfully use contacts have almost 1/5 the risk of undergoing keratoplasty. So I just thought this was a really great article to go out and is hopefully, getting to our corneal colleagues that don't do a corneal transplant right away. Let's consider an RGP, hybrid, a scleral to see if they may get functional vision non-surgically first. So again, corresponding, optic nerve testing, you can see in that patient from earlier significant damage to his optic nerve because of the transplant secondarily. Another case where complications developed after transplantation for keratoconus, you can see the tubes, you can see the challenges I had with fitting his eye. Unfortunately, he's 51 now. I just saw him, I think, last week. He had a transplant 20 years ago in his 30s when specialty contacts weren't as common and robust and prevalent as they are today. He developed secondary glaucoma, had tube shunts, somehow developed strabismus and endophthalmitis after his strabismus surgery. And now he's monocular. He has hand motion vision. Doesn't even matter if I can fit his cornea anymore. He wears an RGP in his left eye with only 20/70 vision. So if we could have potentially avoided that transplant or addressed his keratoconus earlier, maybe he wouldn't be monocular today. Now, I don't want to be such a downer, so here's a successful case. This patient is a 59-year-old gentleman, had transplants 30 years ago. He's wearing scleral lenses. This is the same set from 2 years ago, 20/25 in each eye. So sometimes they do turn out pretty well. Okay, we're to my last myth and misunderstanding. Keratoconus patients are difficult to manage and will take up too much time. Contact lens fittings are too complicated. So, I think I better avoid them. No. Keratoconus is for life. These patients, if you're willing to see them, are lifelong patients. They're dependent on customized devices for their vision. Their condition will persist and may possibly even progress. They may develop complications that you need to be aware of and be able to manage, and they still need routine care. It's also important to note that interventions are now available to help our keratoconus patients. Corneal cross-linking was finally FDA approved in the United States in 2016. And so if we are able to detect keratoconus earlier, treat these patients with cross-linking and hopefully slow and halt progression, they will never need corneal transplants. We also have different surgical procedures that can help to shape the cornea that may allow them to see better even in glasses or get better contact lens fittings. And ultimately, we want to avoid a corneal transplantation. So you must know how to manage these patients. And if not, consider referring for what your patient requires. When seeing patients in a busy practice, and say you only have 20 or 30 minutes for your entire exam and dilation, but you want to educate your patient more about keratoconus, consider rescheduling a separate appointment that you could bill medically as a consultation to go over the results and to discuss, expectations for this patient. Inquire about family members. There's a very exciting new genetic test that is available. Avogen is from a company called Avellino, and you can actually do a mouth swab, send it in, and you can find out your risk for keratoconus development. So something that we have now that we did not have available a couple years ago. Also, don't forget to provide your patients with educational resources, National Keratoconus Foundation, Living with Keratoconus. Don't forget that many of our patients are on social media, and they may be learning about these things even before you're sharing it with them. So don't forget to tell them about resources that they can review on their own at home. Also, you need to have appropriate equipment to manage these patients properly. And if you don't, and you don't want to invest in that equipment, consider referring out for tests. This is a great opportunity for co-management with your local OD colleagues, as well as your local MDs. In summary, there is not one perfect contact lens modality for keratoconic patients. You must consider their disease severity, consider their occupation, hobbies, lifestyle. Are they active? Do they play soccer? Do they, do running? If that's the case, maybe RGPs aren't the best modality. Consider their hygiene. If they have very terrible hygiene and you're worried about them developing an infection, maybe you just need to give them the best refraction that you can in glasses if possible. Be upfront about financial considerations. Be aware that there's a lot of solutions and liquids that they have to buy over time. The good news is that we have many contact lenses to choose from today, and I'm excited about, continued advancements and developments in the future. As contact lens providers, specifically this group that I'm talking to here tonight from the Scleral Lens Education Society, we may see more keratoconic patients, and we may be, very focused on getting the perfect contact lens fit, the best vision possible, the best surface wetting. But don't forget to monitor the disease. So make sure to take off the lens, do corneal mapping, measure their pachymetry, check if their K readings are changing over time. And remember that we now have interventions to halt keratoconus progression. So it's a really exciting time for all of us. I thank you for your attention. You're awesome. Thank you for being here. This is my contact information. Feel free to reach out if you need anything at all. And I am going to turn it over to Dr. Kramer. We have a couple more minutes, but I'm absolutely willing to stay a few minutes after 6:30 to answer some questions. Okay. So, Dr. Kramer.
Yes, thank you so much. That was amazing. Loved it. And we do have some questions. So I'll start off with Jason Huang. Asks, for the 31-year-old male that was referred for contact lenses, would you still refer out for cross-linking before further progression?
So great question. So we did corneal tomography when he presented. Oh, actually, my glaucoma specialist did the corneal tomography, and he had a second one done a couple months later. So he is being monitored. He is 31, and he has mentioned that he's had kind of this weird vision in his right eye for a long time. So it's possible that he developed the keratoconic changes many years ago, and he's just one of the lucky ones where it hasn't progressed beyond this very mild, almost undetectable state. So we are following him very closely for any change in refraction, K reading, thinning, and as soon as we see that, we would recommend cross-linking. So he knows now that he has keratoconus. He didn't know that as of, I think 6 months ago. And so now we've educated him on eye rubbing, what to look out for, asking his family members. And so if we see any change, we would then cross-link him. And I'm also going to see him back to monitor his, glasses prescription as well. As I stated, I didn't fit him in contacts, even though he was referred for contacts because glasses worked so well for him. So, it's questionable. Should you just cross-link every keratoconus patient? Well, I think every keratoconic patient has progressive keratoconus because we're not born with this condition. So it's a matter of where in time we as eye care practitioners detect the disease. And if we detected it too late and they've progressed, but now they're stable, we might not need to cross-link them because there are risks with cross-linking as well. You can develop haze, you can develop corneal scarring, and it can also, lead to infection and other challenges. So I wouldn't just blindly cross-link everybody, but my threshold to refer is pretty low if I see anything, suspicious and if they're young. So he's 31. That's more, it's past kind of the more dangerous, I think, stages of like the teens. So sorry, that was a long answer.
No, that's great. And actually the next question by Luke Hubert is actually a continuation of that question. Is there a certain age where you would first wait to see progression prior to referring for cross-linking versus just referring right away? So do you base it on age or is it something else?
So studies have demonstrated that progression there's the highest risk for progression in young children under 17, and if their Ks are higher than 55. Now I think a K of 55 is way too high. Like, my hope is that we start keeping keratoconus in the back of our mind and screening for it in every child, over 10. And even consider doing a topography or just doing like a baseline topography or tomography, just like we do baseline color vision, just to, catch it sooner. So, oh my gosh, now I rambled so much. Elise, can you repeat the first part of the question?
The question was, is there a specific age that you would say, okay, this person does not need a referral versus they're referred right away for cross-linking?
For cross-linking, okay. So also for cross-linking, keep in mind that, there isn't actually an age limit on how early you can cross-link. The FDA studies, however, had only looked at study participants within a certain age. I'm blanking out on the low age. I want to say it was 16 or 18, I forgot. Elise, do you remember what the low age that was in the FDA clinical trials for cross-linking? It was in the teens, I know.
Yeah, I don't remember the exact age.
Somebody on this webinar has to know. But anyway, it's not contraindicated in individuals younger than that age. It just wasn't tested in their FDA trials. So if I'm seeing a young patient, I might bring them back in 2 months rather than 6 months or a year. And if lots of times for insurances, you do have to demonstrate progression, whether it's in refraction, whether it's in the case, whether it's in decreased best corrected visual acuity. So technically, in order for insurance to approve it, you need to demonstrate progression in this progressive keratoconus diagnosis. So if I'm seeing a young kid, I probably want them to have keratoconus if they're suspicious, if they have family history, if they're rubbing, but I don't think I could justify doing it that same day. I would at least want to see them maybe a month or two later. And in some young individuals, you'd be surprised, they can actually progress in 2 months. So I would see those young kids much sooner, like every 2 to 3 months even. But I would want to demonstrate progression.
Great. Another question by Anith Pillai is, what imaging system are you using?
For monitoring keratoconus or for, okay, actually, I'll just say that I am using the Pentacam tomographer. It's not the newest one that came out. I believe there's like a new Pentacam that came out that's like $50,000 or $70,000 or something. We've had this Pentacam now for several years, so I think it's an older version. But I conduct a Pentacam tomography on every single one of my keratoconic patients as we monitor over time, and on those that I'm suspicious of. We used to have a topographer. I just don't know where it is anymore. So I use the Pentacam to monitor my patients. I don't have a profilometer, so I would love to have a profilometer. I'm trying to work to get that. But the tomography is great because it gives you global pachymetry, it gives you posterior elevation, it gives you, the front curvature, as well as even some higher order aberration data. And yeah, so it's a great piece of equipment to have, especially if you're seeing a lot of keratoconic patients.
Great, and I think we have time for one more question. Do you find that after removing intacts, patients need to be refit, or can they use the same scleral lens?
So if they're wearing a scleral lens, it's possible that the fit will be the same, but you might have a slight over-refraction. As I shared in one case, one of my patients developed corneal hydrops, had significant swelling, edema, and change in the corneal curvature, but she was able to wear her same scleral lens after, and there was only an over-refraction of about a half diopter that we didn't even change. So with intacts, it's going to change the curvature a little bit because, the intacts flattens it, so it might steepen a little bit, but if you have enough clearance, they might be able to wear the same lens and maybe a slight power adjustment.
Perfect. Well, thank you so much for all your time and that amazing presentation. I'm going to announce the next meeting, which is going to be next Wednesday, June 2nd. It is a webinar as well, a 1-hour COPE, and with myself and Dr. Christine Sint, where we'll be talking about interactive scleral lens fitting. So definitely join us. Thank you so much again, Dr. Chu. That was amazing. And thanks again to everyone for joining us tonight.
Thank you so much. Have a great night, everyone.